Hi everyone, my name is Natalie Alvarez and this is my case presentation for CD 535. For this semester, I was placed in-house and assigned 2 clients with Down syndrome, 1 child and 1 adult. I have had the opportunity to experience Down syndrome from emerging language to the adult goals of functional living tasks. However, for this case presentation, I will focus specifically on my 5-year-old client, who has been both a challenge and a great pleasure to work with this first semester of clinic. Miss X is a 5-year, 2-month-old female who is experiencing expressive and receptive language difficulties in addition to some pragmatic issues secondary to Down syndrome. Miss X received early intervention in 2008 through a developmental delayed preschool program. Miss X was then referred by her SLP to the Edgar R. Garrett Speech and Hearing Center for additional services. Miss X was admitted into the clinic in the spring term of 2012. Myself and my co-clinician have had the pleasure of working with Miss X this semester. At the beginning of the term, Miss X's communication was characterized by 1 to 2 word utterances and would supplement vocalizations for single words using American Sign Language. Maladaptive behaviors characterized by hitting, scratching, kicking, and throwing have been consistently reported from previous clinicians. First, I'd like to provide some overall information regarding Down syndrome. In general, Down syndrome is the most common chromosomal cause of developmental disabilities. Children with developmental disorders tend to not develop normal cognition skills and emotional social maturity. These children are typically at risk for ADHD, epilepsy, Alzheimer's disease, dementia, and behavioral abnormalities. Receptively, impaired language comprehension, roughly equivalent to their mental age, is typically seen in children with Down syndrome. Their comprehension abilities often exceed their expressive language and speech abilities. Expressively, children with Down syndrome greatly benefit from early intervention programs, with relatively good language development during infancy and toddlerhood. However, by age 8, language development appears to plateau. According to Joseph Pinter and prior imaging studies, it has been suggested that the neuroanatomy of Down syndrome includes smaller overall brain volumes, with disproportionately smaller cerebellar volumes and relatively larger subcortical gray matter volumes. The overall lower brain weight results in small cerebellum and brainstem, small frontal and temporal lobes, narrow superior gyrus, and smaller hippocampal volumes. I did not assess Miss X myself. However, a formal assessment was conducted by a local Las Cruces early intervention program in 2008. The speech-language pathologist used the Rossetti Infant-Toddler Language Scale, the Hawaii Early Learning Profile for Cognition, also known as the HELP, the Preschool Language Scale, in addition to a speech-language sample and a full oral mechanism exam to qualify Miss X for services. The SLP also referred Miss X and her parents to the University Clinic for additional services. The MacArthur Communicative Development Inventory has been used over the past year as a measure of present level of performance, also known as a PLOP. This inventory has served as a language corpus to help monitor the growth and range of her vocabulary. Since her initial formal assessment in 2008, formal articulation tests have not been administered, since Miss X had not developed an appropriate vocabulary inventory of at least 50 words. Both the words and gestures and words and sentences inventories have been utilized. The most recent inventory was administered this past June. At the beginning of the term, Miss X displayed difficulty with appropriate social interactions, limited interest in literacy, 1 to 3 word utterances, would utilize scripted phrases, and exhibited difficulty with one-step directions and turn-taking. At the beginning of the term, maladaptive behaviors such as hitting and kicking typically occurred as a result of her frustration and her inability to verbalize her wants and needs. She oftentimes would become overwhelmed and in need of some quiet time to regroup before returning to the activity. In addition, Miss X demonstrated difficulty with transitioning between activities, specifically transitioning from the last activity to leaving the session. Based on previous clinician reports and what my co-clinician and I had seen during the first weeks of therapy, we structured our sessions around a play therapy MLU approach. Throughout the term, we have implemented a structured routine that is followed every session. We begin with a dance warm-up activity, followed by an art activity, break time, play activity, and surprise activity. We have worked to increase requests for more in place of her maladaptive behaviors and have utilized strategies such as recast and expansion to increase her MLU. In addition, interactive storybooks and name and letter recognition activities have helped to increase literacy awareness. Miss X has incredible family support, and parent meetings have helped share techniques that can be generalized within the home environment. We have worked to improve peer interactions, incorporate activities that facilitate language, and reinforce the positive behaviors. Miss X has progressed over the semester by increasing her MLU to a consistent 2 to 3 word utterance, with occasional 4 and 5 word utterances. She has benefited greatly from first-then language to ease transitions and has become comfortable with requesting more, which as a result decreased her maladaptive behaviors. Based on the Individuals with Disabilities Education Act triannual assessment criteria, Miss X qualifies for a re-evaluation in which I would recommend be administered this next spring. With her increased vocabulary sufficient to facilitate language, I would recommend that the Goldman-Fristow or the Preschool Language Scale be used. The Goldman-Fristow will provide measurement of our articulation at different levels of complexity, address sounds in words and sentences, assess stimulability, and monitor her growth. The Preschool Language Scale, or PLS-5, will provide scores in total language, auditory comprehension, expressive communication, and as well as monitor her overall growth. In conclusion, it is important to remember that a language disorder affects a child's ability to communicate effectively with peers and adults, both in academic settings and in social interactions. It can affect the child's ability to learn, understand, and respond appropriately to information presented. In addition, her learning readiness and future reading and writing skills can also be impacted. The following are my references for this case presentation. I have also included some websites that serve as some great resources for educating families on Down syndrome. Thank you for listening, and I look forward to any comments or questions you may have.